So we are going live on YouTube now. Wait for a few minutes and then we'll start.
Good morning, Dakshaben.
Good morning. Kem cho?
Came to.
આ બાને મળવાનું થાય છે આપણે every day.
સતીશની દક્ષાબેન સાલ મુબારક.
સાલ મુબારક સાહેબ.
સ્નોફોલ છે કે ત્યાં?
ના હ્યુસ્ટનમાં નથી પણ આજે ટેમ્પરેચર રાતના 25 ફેરનહાઇટ થવાનું છે અને આખો દિવસ 30s માં હતું એકદમ પવન ને બધું બહુ ઠંડી હતી આજે.
પૂરો બંધ હતી આજે.
સ્કૂલો બંધ કરી દીધેલી આજે.
પૂરો બંધ હતી આજે.
Yeah, unusual weather for Houston.
Yeah, exactly.
It is usual weather, Jagdish bhai, because now unpredictability is usual weather.
Yeah.
પણ આજે અમે લોકો ઓહાયોના ફેમિલી જોડે વાત કરી ત્યાં તો એટલો બધો સ્નોફોલ છે ઘરની બહાર નીકળી શકાયું નથી 2 અઠવાડિયા સુધી આઈસ થઈ ગયો છે બધો ઘરની બહાર એવું છે એટલે એની કમ્પેરિઝનમાં વી આર બહુ સારું છે આગળ એવું લાગે
Better at least.
Better, much better.
Good morning, all of you, sir.
Good morning. Good morning.
Good morning, sir.
Good morning, sir.
Good morning.
Good morning, all of you. I am Dr. Jalil from Coimbatore, Tamil Nadu.
Oh, you pediatrician, Dr. Jalil?
Yes, sir. Pediatrician and neonatologist. Last Central EB member.
Sir, he was the EB member last year. He is very active
Yes,
person,
sir.
sir.
Abaisa, I want to listen to him, sir.
Yeah.
This is the fantastic hours, 8 to 9. Keep continuing this for those who are attached to teaching institutions. It will be very beneficial.
Abhay, you can share his number. I'll add him to the Saturday club.
Yeah. Once this
Yeah.
talk is over.
Jalil, this has been going on for last more than 50 years. This is what I was.
Yes, sir.
I will send you a flyer where it is
56
written
years.
on how we are running it. So,
Super academic.
yeah. And because Abhay Bhai is there I see many other friends across the country, like Dr. Bala is also there. Good to see all of them. So, friends, good morning and welcome back to Saturday Club morning meeting. And today, we have a very distinguished speaker, Dr. Abhay Shah. Is a very senior pediatrician from Ahmedabad and a frequent visitor to Baroda for our IAP programs also. A close friend. He has specialized in infectious diseases in pediatrics. He has been very active in our organization, that is IAP, Indian Academy of Pediatrics, and there is a chapter on infectious diseases which he had headed some years back and has contributed immensely to the development of ID chapter. He is also he is presently member of Advisory Committee on Vaccination and Immunization Practices of IAP. It's a very leading committee which frames guidelines for immunization in children of India in private practice, but government of India also takes into consideration its recommendations. Dr. Abhay is a popular speaker of national stature in IAP, has delivered 2 prestigious orations. He is a national contributor and faculty for several IAP modules, and several publications and book chapters are there to his credit. They number more than 50 years. Many things more can be said about Abhay Bhai, but I think we will start with this session. So Abhay Bhai, it's your time for 40 minutes or 45 minutes, and then we'll have some 8-10 minutes for discussion. So over
Sure.
to you, Abhay bhai.
Yes, yeah. May I just share this slide? Yeah.
Yeah.
So hope the slides are visible and audible.
Yes, yes.
So good morning, everybody. Thank you, Dr. Satish Bhai, for this wonderful opportunity and introducing to a very elite group of the people across the country and especially Baroda on this very auspicious day of Vasant Panchami. And one of the important part of this day aspect is the Saraswati Pujan. And I think it is the best time to start the day with a talk. And it's a phenomenal, I would say, a group that is doing a phenomenal activity since like 5 decades. And heads of you, all the Baroda people and person, Dr. Satish Shah, and all the group who has started this. And now the legacy has been continued by our own IFPN friend and our senior person, my guide also in some of the IFP activities, Dr. Satish Pandya. So with these few words, I start my deliberation. And the topic which is given, I think is very pertinent. Ever since Alexander Fleming has invented penicillin, we have a new modality in our therapeutic armamentarium, and that is antibiotic. And when the penicillin was invented, people now started thinking that probably it is now time to close the books on the infectious diseases. But friends, we know whenever the antibiotic is prescribed, either rationally or irrationally, it leads to antibiotic resistance. And in our day-to-day practice, when we use antibiotic even rationally, at times we come to a very perplexing and difficult situation that probably that antibiotic may not be working. So first and important thing, my submission is that all antibiotic failures are not equal to antibiotic resistance. And for that, we need to dig into the details of the disease that we're facing in a child or in a patient. And therefore, let us understand what is an infection. So infection is nothing but a complex interplay between the pathogen and the host. The pathogen may be a virus, maybe a bacterium, maybe a fungus, or maybe a protozoan, and so on and so forth. So if the pathogen is virulent and or if the host is immunocompromised, the infection is not going to respond that as per our expectation, and probably this is the best situation where the antibiotic is going to fail. And this all depend upon the multiple factors. It's a triad, that is the host factors, microbial factors, and the environmental factors. So in a child who is a neonate, a simple looking infection can lead to a fulminant sepsis. An immunocompromised child, a child who is on a steroid, on a chemotherapy, where the fulminant nosocomial infection or the community-acquired infection are going to be very fatal. Similarly, if the microbial load of the organism is very high, the infection is going to be very staunch and will not respond to our antibiotic. The site of infection, the osteoarticular infection, the infection of the CNS are going to be very difficult to handle compared to the infection which are very superficial, that is skin soft tissue infection or the tonsillopharyngitis. Having said that, this infection will lead to different changes. There may be a local effect, that is, it may be in the form of a swelling exudate. There may be some systemic effect of infection we call the SIRS, that is systemic inflammatory response, and it comes with fever, tachycardia, toxemia, anorexia, dehydration, hypoxia, and even organ dysfunction. However, sometimes some of the organism will produce various toxin like endotoxin, and these are the toxin which causes toxin mediated diseases like our toxic shock syndrome or a staphylococcal scarlet cell syndrome. And sometimes the infection also gives rise to an immune mechanism. And this immune mechanism may be remote or may be concurrent with the infection. We have classical example of rheumatic fever. We have the post-streptococcal glomerulonephritis, where streptococcal throat, sore throat will lead to immune-mediated diseases. We have got our hemophagocytic syndrome, where again it's an immune-mediated cytochrome disease. We have got autoimmune hemolytic anemia, which is common with mycoplasma. So even the immune-mediated mechanism can also cause the disease, and in such cases, probably it is not the antibiotic is going to work, probably the immunomodulator is going to work. Similarly, if it's a toxin-mediated disease, it is the antitoxin agents are required, and not only the antibiotic is required. And therefore, a timely intervention is very, very crucial for the favorable outcome of any infection. And if you look, when you are treating a child who has got the infection, then there may be some of the clinical parameters or the laboratory parameters which will guide us whether the child is improving with the prescribed antibiotic therapy or not. And for that, there will be a decrease in the fever, there will be control of the tachycardia, and there will be control in the tachypnea as well. And there will be improving sensorium, the oral intake is good, urine output is good, and child looks good. So it is not only the fever, but we have to look comprehensively at the child, how the child is behaving. Similarly, there will be a reduction in the use of the vasopressors. There is a reduction in the oxygen requirement. That is the organ dysfunction, which was previously taking place, has now started improving, and it will be again reflected in the lab parameters like improving counts, improving CRP, and improving procalcitonin. So this is how the improvement is expected in a child if the antibiotic is working. However, there are certain situations where the antibiotic is not working, and the factors may be they are iatrogenic factor or they may be a non-iatrogenic factor. So there may be no response at all, there may be a slow response, or there may be a complication, or there may be early response, but again there is relapse, that is a recurrence. So all these factors are considered, all these issues are considered as a non-response to our antimicrobial therapy. I'm very sorry to say that most of the time this non-response is mainly iatrogenic, means we as a clinician are always at the fault majority of the time because of the incorrect diagnosis, faulty interpretation of the investigation, whether investigation not set in a time. The sample has not been properly collected. The sample has not been properly processed or transported. So these are the iatrogenic factor. And there is poor management of the vitals. It is very, very important that for an antibiotic to work, you need to take care of the airway, breathing, and circulation. And last one, there is a wrong choice of the antibiotic. Suppose a child who has got a gram-negative infection, your vancomycin is not going to work. So selection of the antibiotic is very, very important. However, certain things are beyond under control. We have got the many antagonist factor, we have the immune-mediated fever, we have the cytokine storm associated with the infection, and we have other eagle infection where the high antibiotic concentration is failed to be achieved. So these are the factors what iatrogenic and non-iatrogenic. Among these, the iatrogenic factors are very, very important. Now, when there is a non-responding infection is there, again, the back to basics is very, very important. And that is history, history, and history. When the child is not responding, we have to go in the details of the history. You have to rephrase it. He has to re-evaluate it and try to snatch maximum from the parents that what the child actually is suffering from. Similarly, a serial assessment of the vital signs, blood pressure, and SpO2 is very, very important. And most important, the laboratory parameters, the serial lab parameters is very, very important. A single parameter or a parameter on day one is not going to be helpful. We have to be very, very cautious. And while doing all this exercise, always take care of the airway, breathing, circulation, and maintain the euglycemia all across your therapeutic period. Remember that a child of pneumonia is going to die of hypoxia, not because of the lack of antibiotic. A child of gastroenteritis dying is going to die of the hypovolemic shock, not because of the want of antibiotics. So maintenance of the ABC and blood sugar level is very, very important for the antibiotic to work. So with this preamble, I will take you a few of the cases that I've come across. A 8-year-old child who has got a fever, a sore throat, and there was general body ache. There was some exudative follicles on the tonsil, and the child was treated as acute tonsillopharyngitis with amoxiclav. Now, as you know, the drug of choice for tonsillopharyngitis is amoxicillin. We should not give amoxiclav because we want to give a narrow spectrum antibiotic. Still, amoxiclav is going to work, but here probably there is no improvement even after 5 days of the amoxiclav. So what went wrong? So when we examined the child, there was febrile ill looking, there was periodema, there was maculopapular rash, there was bilateral cervical lymphadenopathy, there was hepatomegaly as well as splenomegaly. So I think a very simple tonsillopharyngitis, why should have this lymphadenopathy? Why the child should have a hepatosplenomegaly? So you have to think the child comprehensively, and you should not just focus on the local symptom or the local sign. That is the message that I want to give. And when we examine the child, you can see there was leukocytosis, there was thrombocytosis, and on peripheral smear, there is atypical lymphocyte as well. And we can see this typical is a large lymphocyte with a big abundant cytoplasm, and you can see that there is a peripheral indentation of the lymphocyte with the adjacent RBC. That's very classical atypical cell, and this is very, very characteristic of the infectious mononucleosis. And when we did a IgM for the viral capsid antigen for EB virus, it was positive. So the child who was looking like a simple tonsillopharyngitis because of streptococcal infection turned out to be a case of infectious mononucleosis caused by F-Y virus. So we have to be very, very alert. Why a child of simple tonsillopharyngitis should be not responding to antibiotic. So here changing the antibiotic or adding the antibiotic, expanding the spectrum of antibiotic is not going to work. What works is that you need to come to the definitive diagnosis. And therefore, when a tonsillopharyngitis is not behaving as tonsillopharyngitis, then you have to think that this is a part of the systemic infection. And the common infection that come out is a diphtheria. You can see the diphtheria. You can have this Epstein-Barr virus. You can have this adenovirus. And sometimes the Candida white fungus can be sitting on the tonsil and it looks like a purulent tonsillopharyngitis. So I think it is very, very important that let us have a thorough head to toe examination, even if it's a localized infection, like localized looking infection, like tonsillopharyngitis. There's another case, a fever, cough, 5 years child, a short history of fever and cough, treated by family physician with cefixime. Again, friends, cefixime is not the drug for the infection above the diaphragm. It is required for the diaphragm. So your cefixime is not going to work. The child was on X-ray, diagnosed pneumonia. Pediatrician start IV ceftriaxone, but in spite of this good antibiotic, that is ceftriaxone, there is no response after 72 hours. Child continue to have a fever and there is increasing tachypnea. So if there is a no response, it is a time to re-evaluate the child. Again here, please do not go on adding the antibiotic. Do not go on expand the spectrum, but try to evaluate why my antibiotic is not working in a commonly acquired infection in an immunocompetent child. And look at this child. This child was having a pleural effusion, and sometimes it may be a complication because of the lung abscess. So here, the most important thing that once the antibiotic in a commonly acquired is not working, the commonest thing is to rule out the complication. Either it can be a effusion or it can be a rarely, uncommonly, a lung abscess. So in this child, the child was sick, persistent tachypnea, tachycardia was there was decreased left entry. You can see there's anemia, SCPT is 146, and there is a moderate pleural effusion. And the pleural tap was done, and we did the gastric aspirate for AFB to rule out tuberculosis because the child was referred for us because as a case of tuberculosis. The mycoplasma IgM was found, blood culture was found, and because there was no response to antibiotic, we started clarithromycin empirically to cover the atypical organism like mycoplasma. And it's a straw color fluid. pleural fluid examination, protein 3.4. So whenever there is a straw color fluid, our earlier teaching is that it is equal to tuberculosis. No, this straw color fluid can be either because of the mycoplasma or it can be because of the partially treated bacterial infection. So child has been exposed to multiple antibiotics. So this straw color fluid is not always equal to tuberculosis, and therefore we went for the gastric analysis, AFB gene expert, everything was normal. And you can look, the cell count is 1800 and the culture was sent, which was negative. CB-net for tuberculosis gene expert was negative, and to our surprise, the cold agglutinin was positive, mycoplasma IgM is positive, and pleural fluid was negative for tuberculosis, both AFB smear as well as the CB-NAT. So friends, the second message is there, in a case of community acquired pneumonia, when there is no response, always first rule out fluid collection. And once there is a fluid collection, always drain it. No amount of antibiotic is going to work unless you drain the fluid. It will also give the opportunity for the source control, and it will also give us a sample for the microbial diagnosis. And in this case, it turned out to be a case of mycoplasma. So the first important is the complication, that is effusion. It turned out to be a different bug like mycoplasma. Of course, it can be TB or fungal in a especially an immunocompromised child, or it can be a drug-resistant pneumonia where it may be caused by methicillin-resistant Staph aureus, multi-drug resistant tuberculosis, or it can be a drug-resistant streptococcus pneumoniae, of course, which is not there currently in India, but we are facing a lot of MRSA and a lot of MDR TB as well. So a non-responding pneumonia is always a different big game and is not equal to adding number of antibiotics one after the other, but you have to evaluate it in the right perspective. Another child, a 9-month-old child, you can see the malnourished child, 6.6 kg, has a very long history, fever often for 3 months, cough after 3 months, child is not eating well, admitted thrice for pneumonia, multiple causes, right from the amoxicillin to meropenem to levoflox, and even empiric AKT is also been started. Remember friends, to start an empiric AKT in 2021 is a crime. We need to have a microbial diagnosis, and when we did a serial CBC, the counts were ranging in the form of 14,000 to 28,000. The CRP is ranging in the form of 40 to 60. ESR is ranging in the range of 20 to 50. Montoux test was done twice, it was negative. Blood culture, urea, electrolytes, everything was normal. And you can see this X-ray. It is just like a Xerox copy. See, the same X-ray of 3 months in spite of multiple courses of antibiotic. And we evaluated this. Gastric aspirate was negative, CB-net was negative. We did HIV testing. Parents of both the X-ray was normal. ESG also of the chest, which was not suggestive of any fluid of abscess. And we did a CT test, which was again consistent with the pneumonia, and there is no other additional information. So it is it's a non-resolving pneumonia, not responding to multiple courses of antibiotics. So what next? We did a bronchoscopy and we did a bronchoalveolar secretion. You can see the bronchoscopy note here, and it turned out to be a tuberculosis, not only tuberculosis on gene expert, but it was a rifampicin disease. So it's a multi-drug resistant tuberculosis. The message what I want to say that when there's a non-resolving pneumonia, you have to think of the drug resistance itself. So we have seen a complication in the form of empyema in the first case. We have seen the different bug in the case of mycoplasma. And here is again a different bug, but at the same time, it is a resistant bug. So all these are very important as far as the non-resolving pneumonia is concerned. And friends, it is also important that all obesities are not pneumonia. This is a child who has a persistent obesity, and the sonologist has diagnosed it. Remember, sonologist has given us the idea that it's an ancestor diffusion and it needs to be tapped. But when we did a CT, it turned out to be a diaphragmatic hernia. So remember, friends, all obesities are not pneumonia. And as they are not pneumonia, they are not going to settle with the use of your antibiotic of any spectrum. So similarly, it can be any tumor, it can be a cyst, or it can be any congenital malformation, which can present as obesity and looks like pneumonia on X-ray. Another 11-month child who has got the weight is little less, a fever rapidly in 10 days, X-ray was having pneumonia. You can see the count, 6,400, nothing much in contributory. Child was given cefixone, amikacin, no response. Again, the pediatrician adds piperacillin, tazobactam, azithromycin, no response. So, in the tune of 1 week, only 4 antibiotics have been started. Still, the child is not responding and was referred to us what a worsening tachypnea. We sent the blood culture, and what we found in this case that there was a progressive leukopenia. The count which started with 6,400 has come down to 5,400, then 3,400, and then even 1,100. So there's a progressive leukopenia. And when we did the X-ray, there was a necrotizing pneumonia. You can see this the tissue breakdown. You can see this honeycombing, and it's a very, very classical necrotizing pneumonia caused by staphylococcal infection. So whenever there is a necrotizing pneumonia, especially a malnourished child, when there is rapidly changing X-ray, when there is worsening leukopenia, think of the MRSA. And this MRSA is producing a toxin which is known as penton valentine leukocidin. And as the name suggests, it causes lysis of the leukocyte. And therefore, the child was having a progressive leukopenia. And so you can see that this is cephalococcal and there is a leukocyte. There is a total destruction of leukocyte over the period of 6 months. So there is a why there is a progressive leukopenia because of this PVL toxin. So we started with the vancomycin. To take care of a toxin, we started clindamycin, and MRSA was isolated. So the MRSA necrotizing pneumonia. So there are a few of the other cases of the necrotizing pneumonia. You can see this hydropneumothorax. You can see pneumothorax. You can see the tissue pneumatocyl tissue breakdown, and you can see even the empyema. So all these different changes can occur in a necrotizing pneumonia. So these are the situations which does not require only antibiotic. Only antibiotic is just a part of the spectrum of the treatment. And therefore, these are the cases which require a multiple disciplinary action, where they require surgical intervention, they require debridement of the tissue, they require good nutrition, and they also require chest physiotherapy. So the necrotizing pneumonia is beyond something antibiotic. And so all these factors are very, very important for the antibiotic to work. And sometimes in a very bad situation, sometimes the vancomycin itself is not working. And this, because these are the ways of antibiotic resistance. And now we have started seeing vancomycin resistant intermediate as well as vancomycin resistant staphylococcus aureus. And these are the situations where there is a VRE or VRSA. These require even higher antibiotic, which may be in the form of daptomycin, which may be in the form of quinpristine, or which may be in the form of ceftriaxone and fusamil. But I will not go details of this. But again, daptomycin has started. We are using often daptomycin uncommonly when there is a no response to vancomycin in a proved MRSA case. A simple case, enteric fever, a 5-year, look at the weight, 16 kg, fever, abdominal pain, and the Vidal was positive. We do not do Vidal, but it was positive. It was a referred case, but we did a culture and there is a S typhoid. So the culture proven typhoid fever, sensitive to ceftriaxone as well as ceftriaxone tazobactam. But the pediatrician start the ceftriaxone in a small dose, 500 milligram per PD. You know the dose of enteric fever of ceftriaxone in enteric fever is 100 milligram per kg. Therefore, the child nearly requires 1.6 gram of the ceftriaxone. Instead, the child receives only 1 gram per day. So there was no response. So this no response is mainly because of the inadequate dose in a case of typhoid fever, right? So since there was no response, the child was switched to ceftriaxone and tazobactam. Again, amikacin was added. Again, there is no response. So I think there is totally a misuse of all the 3 antibiotics in a course of 5 days. First, an important thing that amikacin is not going to work. Why? Because this aminoglycoside is not working on the intracellular organism like Salmonella and Shigella. So it's our knee-jerk reaction. When there is a gram-negative infection, we start aminoglycoside. So it's a wrong notion. It is not going to work. Remember, similarly, our typhoid bacilli do not produce any beta-lactamase enzyme, and therefore there is no role of adding tazobactam or any of the beta-lactamase inhibitors. So all these are the misuse of antibiotic, and therefore you know what is the mechanism of the, what is the type of the organism is very, very important for the success of this antibiotic therapy. So in an enteric fever, it is very important, even if you start an antibiotic in a right dose, that is ceftriaxone 100 mg per kg per day, or a cefixime 20 mg per kg per day, your typhoid fever is not going to respond on the first 4 or 5 days. There is sometimes there is a delayed effervescence. Fever may start subsiding by day 6 or by day 7. But if the child is doing well, is not toxic, is otherwise good, there is no need to be panicked, and there is no role of adding the drug. So no need to change the antibiotic, and I've already discussed this. So it is a very, very important that a delayed effervescence is known and an adequate dose is required, because typhoid are the intracellular organism, so higher doses are required. And in spite of giving correct dose, if there is no response, then do not go on adding the antibiotic, but evaluate the case. Is there is a co-infection, whether the child has associated UTI, whether the child has got thrombophlebitis, it is very, very important. Sometimes the child may have splenic abscess. Now we used to, in last 3 years, we have got 2 or 3 cases of splenic abscess in a typhoid. You have to think of the complication like HLH. And fortunately, we don't have ceftriaxone resistance in India at present. So do not think that now the enteric fever are the ceftriaxone resistant. No, they are sensitive, but they require a little more time to get the effervescence. Another case, 2 cases I am taking simultaneously. These of the meningitis. A newborn is admitted on day 7 with seizure lethargy. Child was given cefotaxime for 3 days intramuscularly because of the history of premature rupture of membrane. So it's again, when the child is given unnecessary antibiotic, and when the child is given unnecessary antibiotic, it will predispose the child to a potential organism like ESBL, that is extended spectrum beta lactamase producing organism, and the child was CSF was done. It was suggestive acute bacterial meningitis, and pediatrician start piperacillin tazobactam and amikacin. So previously it was cefotaxime was given, now piperacillin tazobactam is given, now amikacin is given. Again the child deteriorates. So what has gone wrong? A 16-month-old child diagnosed as bacterial meningitis was given ceftriaxone and amikacin, but on day 4 there is no response. Child again developed convulsion, consciousness is not improved, and again vancomycin and meropenem. So there is still no improvement. So what has gone wrong? Multiple antibiotics have been used in both the case, neonate as and grown up children in a case of meningitis. So let us look at the first case of newborn. Here the likely organism is ESBL because there is an exposure to a 3rd generation cephalosporin, and therefore we need to use an antibiotic which is a good CNS penetration and is a bactericidal drug. Remember that the child has got given piperacillin tazobactam. Remember that this tazobactam, any term antibiotic, has a poor CNS penetration. So in spite of a good coverage against ESBL, in spite of a broad spectrum antibiotic, this piperacillin tazobactam is not going to work, and septic shock, septic meningitis are the situation where you have to hit very hard, and this is an ideal case to upfront start the meropenem. So because there is a poor choice of antibiotic, it is not working. So here in case of ESBL neonatal meningitis, the drug of choice will be a carbapenem because there is a good CSF penetration, there is no inoculum effect, and it also acts against the ESBL, which produces AMPC. So here piperacillin tazobactam, even augmented cephalosporin like ceftriaxone tazobactam is not going to work, and cefepime is also not going to work because if the microbial load is high, the MIC keeps on rising, which is described as a inoculum effect. So all these factors are very important when you choose an antibiotic for the success therapy. In case second case, a 16-month which was having a meningitis, there was no response to ceftriaxone. So when there is a correct antibiotic is used in a correct dose with a good CNS penetration, then remember that by day 3 or day 4 the child must improve. Here the child worsened. There is reappearance of the conversion. The altered sensorium has gone further deep. Altered sensorium has got further worsened, and then it is a time that we have to think of the complication of the meningitis. And we did a MRI which was suggestive of a subdural collection, frontoparatal region with a communicating hydrocephalus. So remember that in a case of acute bacterial meningitis, when the appropriate antibiotic is not working, think of the complication of subdural collection, ventriculitis, sinus thrombosis, or one of brain abscess. If the fever is only is an issue, but otherwise child is neurologically improving, then think of the peripheral causes like thrombophlebitis or UTI. So all these are required. All this evaluation of the case is very, very important rather than go on adding antibiotic one after the other. This is another child, a 4-month-old child who has got a recurrent UTI because of the grade 4 and grade 5 VUR. So his child was in bilateral. Child was operated for the vestibular anus and there was urinary implant. To our great surprise, urinary culture, child was having a severe urosepsis with dehydration, acidosis, and shock, and urine culture show E. coli. But look at the sensitivity pattern. All are resistant, including carbapenem. So there is a penem resistance ESBL even in E. coli. Forget about Pseudomonas, forget about Proteus, forget about Clostridia. Simple organism like E. coli has now shown resistance to even carbapenem group of drug, and they require only drug like polymyxin or a tigecycline. So whenever there is a carbapenem resistance, remember that we have got a very few limited choices, and that is colistin, tigecycline, fosfomycin, amyoclocacid, and we got a newer ML. But remember that these are the drugs we should never use empirically. They must be guided by a sensitive report, and they should not be used as a monotherapy. You have to have a combination. You can have a colistin with amyoclocacid, you can have tigecycline with meropenem, you can have a high dose meropenem. So various combination permutations required for the antibiotic work. I will not go in detail of this, but carbapenem resistance is rising. We see a lot of cases, and therefore antibiotic stewardship is very, very important. So we have got the new agents, that is a cephalosporin with beta-lactam to take care of this carbapenem resistance. Out of this ceftazidime and avibactam is started available in India, and it has been approved by FDA and is a good drug for the complicated intraabdominal infection along with meropenem. Also remember the pharmacokinetic and pharmacodynamics of the drug. The dose duration is very, very also important. So if there is an inappropriate antibiotic dosing, there will be too small dose to reach the desired number. If the interval of the two doses is too long, it will fail to sustain the desired MIC. A delayed administration will be detrimental in a serious condition like septic meningitis or a shock, and therefore a wrong route, that oral or intravenous in a sick child. So it is very, very, all these factors are very important. Out of these, the most important among these is the ESBL organism. Always treat the report, treat the child and not the report, because there is lot of in vitro in vivo mismatch. It is especially found in case of UTI. The in UTI, you see how the report where there most of the antibiotics found to be resistant except the carbapenems. But if you look at the child, a simple cefixime is working. So this in vivo in vitro mismatch is very, very important, and you have to take care of this factor as well. And when we are choosing the antibiotic, we have to take care of the type of the antibiotic. What is the mechanism of action? What is the time dependent and concentration dependent bactericidal activity or not? And this will help us to decide whether the child requires loading dose, like in a case of vancomycin, a frequent dosage, like in a case of cefotaxime, or a continuous deep infusion, like in a case of meropenem or ceftriaxone. So this time dependent, concentration dependent pharmacokinetics and pharmacodynamics will help us to optimize our empirical therapy when the culture and sensitivity is not available, or when the culture and sensitivity report are negative to almost on the antibiotic. Similarly, our source control is very, very important. It is especially infection in the case of skin and soft tissue infection, intra-abdominal infection. So you have to drain the fluid out. You have to remove the you have to do the debridement of necrotic tissue, amputation of necrotic tissue. A foreign body has to be removed, and the devices which are there, like a catheter-related infection, you have to remove the catheter. So unless you do the source control, your antibiotic is not going to penetrate at the site of the infection. So this source control is very, very important. So it is classically, it is required in a case of necrotic fasciitis, where the tissue debridement, emergency tissue debridement with a surgical team is very, very important. Otherwise, your antibiotic is not going to penetrate at the site of the infection. Similarly, in case of skin and soft tissue infection, I think like Staphylococcus syndrome, a good tissue care is very, very important along with the antibiotic coverage like cloxacillin and clindamycin. A biofilm, again the same thing. It is required to take care in a condition like infective endocarditis, a catheter infection, shunt infection, device stent. So get rid of the offending device, remove the biofilm, the same antibiotic is required. So there is no point in adding antibiotic one after other, but you just remove the device, the same antibiotic is going to work. Similarly, if there is a polymicrobial infection, a single antibiotic is not working because you have to take care of the gram-negative organism, you have to take care of the gram-positive organism, you have to take care of the anaerobes. The classical example is intra-abdominal infection, necrotic fasciitis, vein abscess, fever in neutropenic child. So all these require even anaerobic coverage. And the anaerobic coverage is provided by few drugs like amoxicillin, metronidazole, clindamycin, piperacillin tolobactam, ampicillin sulbactam, and all panoms. These are the drugs which help us to cover even anaerobic organism. These are the situation we have to act hard, act fast, hit hard, and set the appropriate culture. Now, along with the infection or during the post-infective period, some immune mechanism take place. And when this immune mechanism is, there is hyperimmune response, there is a cytokine storm caused by the activated lymphocyte and histiocyte. It is classically seen with the salmonella, dengue, tuberculosis, and the condition which we refer is as the HLH, that is hemophagocyte syndrome. And it is very, very important. In this case, your antibiotic has no role, but you have to take care of the immune phenomena. These are drugs which require steroid. These are drugs which require immunosuppression. So here, the role of hematologist is very, very important. But I want to say that whenever the complication like HLH is there, they require immunomodulator rather than expanding the spectrum of antibiotic. In addition to that, host factors are required: a severe malnutrition, HIV, diabetes, patient on steroid, neutropenia, immunodeficiency, cystic fibrosis, asthenia. They are more prone to unusual bug, unusual course of the simple bug, and unusual site of the infection. As a 7-month-old child, a Himanshu has been treated with bronchiolitis with antibiotics, ceftriaxone, azithromycin. Discharge, child continues to have hypoxia. You can see this hypoxia. Again, the child was admitted with the same complaint. You can see some interstitial pneumonia is there. Otherwise, child, there is no consolidation, there is no lobar pneumonia. 2D echo was done because of a recurrent chest infection. It was normal. Child was investigated for electrolyte culture. Everything was normal. But to our surprise, there was some thrombocytopenia. So this one soft sign was there on a thrombocytopenia. And we did a repeated CBC over the course of 17 days of admission. And you can see that the hemoglobin was 10.3. Then you can see the total count. It started dropping. But what is more important, that the platelet, which was on first admission was 3.1 lakhs, has come down to 93,000 over a period of 15 days. So there is a fall in the thrombocytopenia. So here is a child who has got recurrent chest infection, who's not maintaining the oxygen saturation with hypoxia, and there is a isolated thrombocytopenia. So when there is hypoxia is there, you have to think of the condition which causes interstitial lung disease. The classical is mycoplasma, H1N1, adenovirus, HIV, and pertussis is there. And child was also in top, was having a isolated thrombocytopenia. And this isolated thrombocytopenia is very characteristic of HIV. And we did the HIV PCR was done, and the child turned out to be a HIV. So this interstitial pneumonia is because of the HIV, and therefore the child was not responding to multiple courses of antibiotic. So when there is a recurrent wheezing, a child of so-called bronchiolitis is not behaving like bronchiolitis, you have to rule out all other conditions like congenital heart disease, GRD, immunodeficiency, vascular malformation, immunodeficiency, and even cystic fibrosis. Another case, a primary, you can see very low birth weight child, given surfactant was given, ventilator is given, umbilical vein was given some antibiotic, but child developed sepsis on 8th day, and child was given E. coli, culture showing E. coli, which was sensitive to meropenem, but in spite of meropenem, which was sensitive, child is not working. So here, the child was an immunocompromised, very low birth, was on multiple gadgets, and so it's a classical case of a fungal infection. Remember where when there is a sepsis-like scenario, when there are presence of predisposing host factors like immunocompromised child, neutropenia, central lines, previous antibiotic therapy, and when there is a persistently high acute phase reactant and cultures are repeatedly negative, you have to think of the fungal infection. And in this case, you have to add antifungal and not the antibiotic. So it is very, very important that even non-bacterial infection look like a sepsis, and that proper antifungal therapy is what is that required. Similarly, you may end up treating a case with a non-infectious condition, and classically, a Kawasaki is often mistaken for scarlet fever, vice versa. A celiac disease is often treated with a cox abdomen, a lymphoma is often treated with a tuberculosis. So these non-infectious conditions are very, very important to rule out. So friends, my verdict is that if there is a no response to antibiotic therapy, it is the antibiotic failure and not only antibiotic resistance. Antibiotic resistance is only a small component of the whole spectrum of the antibiotic failure. And let me remind, my first case of tonsillopharyngitis was treated as step 4, was having a Epstein-Barr virus infection. Case 2, 3, and 4, a non-dissolving pneumonia, turned out to be a case of mycoplasma effusion, MDR-TB, and PVL producing MRSA, that is resistant organism. Case 5, typhoid fever. 5, failure of antibiotics because of the suboptimal dose and irrational antibiotic combination. Case 6, 5 and 6 and 7, acute bacterial meningitis, poor choice of antibiotic where there was no CSF penetration of the present Enterobacterium, and there is post-meningitis complication in the form of subdural effusion. Case 7, the recurrent UTI because of the carbapenem resistance, because the device was there and the source control was very, very important. Case 8, where the necrotizing fasciitis and Stafford syndrome, a debridement of tissue is very important, along with the antitoxin drug like cloxacillin and clindamycin. And HLH is very common nowadays in condition like typhoid, dengue, and even brucella. So, and last one that we have to think of immunocompromises like HIV in a child who was having an interstitial pneumonia, or even a neutropenia in a child who is on a chemotherapy. So, if there is a non-responding infection, always address the correct antibiotic in an antibiotic correct dose, taking care of the pharmacokinetic and pharmacodynamic. If there is a hidden pus, it may be empyema subdural collection. You have to drain it. Always look at the foreign body if there is non-dissolving pneumonia or the recurrent pneumonia. Always take care of the necrotic tissue, especially in polytrauma burns or even Stevenson-Johnson syndrome. Take care of the unresolved bug like mycoplasma, TB, viral, leptofungal, or rickettsia. It may be improper diagnosis, maybe treating a non-infectious condition with the help of antibiotic. Then comes the antibiotic resistant bacteria. And always remember a post-infectious immune phenomena like HLH, and never ever forget the host factors, which may be immunocompromised like HIV, or there may be some special situation like cystic fibrosis, asplenia, and splenectomy. So all these factors are very, very important to address the issue of antibiotic failure. So the command is to follow for the rational therapy, find out that we are dealing with a true bacterial infection. You have to first stabilize the child, take the appropriate sample, and confirm that you are dealing with a true bacterial infection. Start the antibiotic if the child is toxic, otherwise you can wait as well. Use the antibiotic in the right drug for the right bug in a correct dose, duration, interval, PK/PD, and duration. If there is no response, think of the simple complication, do a course control, and then think of the drug resistance and changing the drug. If again this exercise has been done and it is not working, think of the host factors like immunocompromised state, or revise or diagnosis, maybe looking at an infection mimic, or maybe a special situation like cystic fibrosis. And remember the golden words from our own Dr. Amrekar sir, that if 2 sets of antibiotics is not working, revise the diagnosis, do not change the antibiotic. So with this, I thank all of you for a patient hearing, with a message that unethical deeds don't occur out of desire to do the evil, but because of a lack in the thought process. So it is a lack of the thought process that has led to antibiotic failure rather than antibiotic resistance itself. So thank you very much for patient hearing. Thank you so much. It was my honor and privilege to be amongst this learned group. Thank you so much.
Thank you, Dr. Abhay. Wonderful presentation as usual. And by case illustrations, you have given very crisp messages. It was a very precise, comprehensive, I would say, a discourse on rational use of antibiotics, because that's one issue which is a matter of great concern because of the rising antimicrobial resistance. And I see a lot of stalwarts in infectious disease in IAP here. There is Dr. Bala Subramaniam, there is Dr. Suhas Prabhu,
Oh,
So your comments are welcome. Before that, no, I will take up one or two comments and questions from the audience. Dr. Jalil is asking about VCA and VBA. Any specific choice?
no. As far as the infection monitoring, VCA is very important. We have to viral capsid antigen antibody IgM is the gold standard, not VBC.
Right. He also wants you to elaborate on PVL.
Yeah. So see, there are a number of toxins produced by different bacteria. Out of this, as far as staph is concerned, we have got the toxin that is PVL, that is penton valentine toxin. And as the name suggests, it is a leukocidin toxin. So whenever you are dealing with a child who has got staph infection, is not responding and have a persistent leukopenia, you have to think of that these are the staph which produces PVL. It is very difficult to go for the assay. It is not also available in most of the center. It's only research institute. But this clinical leukopenia in a worsening child who has a staph infection is a very correct PVL. Second, remember that PVL occurs only with MSSA and only with CA-MRSA. It is not with the hospital-associated infection. So majority of the community-acquired staph infection and even MSSA can have a PVL toxin. So it is clinically very difficult to find out whether we are dealing with a MSSA or MRSA. But if the child has leukopenia, I think we can say that it's a PVL producing staph. Of course, in a worsening child.
Thank you.
Yeah.
Yes, Dr. Jalil.
Thank you, sir, Abhay sir, for your wonderful, excellent presentation. This is again with isolated thrombocytopenia. As a newborn specialist, we come across a persistent refractory thrombocytopenia isolated, especially in a fungal sepsis in newborns.
Yeah.
You have mentioned about the HIV is a very good message for all of us. Thank you, sir.
Yeah.
Thank
So
you.
I think
We have Dr. Ritesh Shah with us. Sorry,
Yes.
Abhay.
Yes, sir.
Please complete your sentence and then I will.
No, yeah, I think thrombocytopenia is one of the hallmark of the neonatal sepsis, and when it is there, where the cultures are negative, antibody not working, you have to think of the fungal sepsis. I agree with you, Dr. Jalil. Point well taken.
Yeah, Dr. Ritesh is a intensivist in Baroda. Ritesh bhai, would you like to comment on adult situation?
Yes. Thanks, Abhay, for the wonderful talk. I completely agree that, antibiotic stewardship, I keep on telling my residents right from their day one that know your bug and know your drug. And just to share with you, I developed one protocol of 6S in, antibiotic prescription. I would just like to share that, before you write down antibiotic, the 6S is necessary to know, that is, site of the infection, severity of the infection, status of the patient, whether immunocompetent or immunocompromised, spectrum of the drug, you need to know the drug. And fifth thing is the sensitivity, drug sensitivity, that you need to send a culture. And last but not the least, it is, I would say, non-scientific, but have some sensible decision. Sixth S is most important, that have some common sense with science. So I had made it sixth S as sensible decision in combination with common sense and science. So this 6S you need to know before you write down just antibiotic as a knee-jerk reaction. Nowadays, antibiotic is a knee-jerk reaction even from layman, like azithromycin misuse. We know that pandemic has turned azithromycin into miserable, kind of resistance. Maybe in the next 5 years we'll come to know. So thanks for the wonderful talk. I think we keep on discussing with antibiotic stewardship. That's future to go. Thank you.
Thank you, Dr. Ritesh, for these good comments. Anybody else? Dr. Bala, you want to say something?
Nothing, sir. Actually, very clear presentation, sir. Very refreshing one. It will be very useful in our day-to-day practice, sir. We will keep everything in mind. That's a valid point here.
Dr. Suhas Prabhu is not there, but he had put few comments, Dr. Abhay.
Yeah.
One was regarding empyema, other was the bacterial gastroenteritis causing sepsis. There was a comment I saw in the chat box, but I don't know what relevance with he had put that comment. Anyway, if there are any other comments, please.
Abhay sir, you have mentioned about the levofloxacin in one of the complicated pneumonias. Actually, in the antibiotic stewardship, we are not supposed to prescribe levofloxacin.
Yeah.
Because it is a line of drug for anti-tuberculosis drug.
Yeah. So actually, we started this when we saw we started this levofloxacin when we started the straw color fluid, because it was not fitting with tuberculosis, and by that time the gene expert report has come to negative, and the child was already given azithromycin outside. Child has received azithromycin outside. So we thought that the macrolide resistance is on rise for mycoplasma, and as it was a very bad child, we started levofloxacin.
For the carbapenem resistance, sir, apart from the colostine combination, the newer drugs, what you have mentioned, is it available, sir?
Yes, the tigecycline is available, but probably it should be given above the age of 7 or 8 years. There's ceftazidime, avibactam is available. Okay. And phosphomycin is available. I think we are, our intensivists are using it left and right. I have been using it 2 or 3 times in a year.
Dr. Ankit wants to ask, yes.
We are proud to announce, sir, at the National Infectious Disease chapter, we are given the privilege of carrying it in Coimbatore, sir.
Yeah,
all are welcome.
NCPID is at Coimbatore, I know it. Yeah.
Yes, sir. Coimbatore is a lovely industrial city. Yeah. Please visit, sir. Please come.
Yeah.
Thank you.
Dr. Ankit wants to ask about treatment of mononucleosis, infectious mononucleosis.
Yeah, so infectious mononucleosis is a viral disease. And as you know that a virus is known for the dissemination, where bacteria will cause a localized disease. So in a virus, infectious mononucleosis, we have got a sore throat, we have got exudative tonsillitis, we have got hepatosplenomegaly. Sometimes spleen is so large that it is prone to even rupture. So as far as treatment is concerned, just like any virus, there is most of the virus, there is no specific antiviral therapy. What the child needs are symptomatic treatments. If the child has got the fever, you give paracetamol. You can have some betadine type of gargles because of the bad exudate in the tonsil. As far as spleen, it's very important to have a protection against spleen. So ask the parents not to allow the child to participate in a contact sport. And if there is a severe respiratory distress, or if there is a very bad child, in that case, a steroid is required. Otherwise, most of the time, it's a self-limiting disease.
Dr. Manoj is asking how common are autoinflammatory syndromes as cause of fever in children?
Say, in a typhoid fever, we often say immune-mediated fever. Means the child has got a culture positive salmonella. We have started chapter cefixime. Child is doing comprehensively well, was doing well, eating well. There was a febrile period, and again starts after 4 or 5 days. Again, there is a fever. So this type of the immune-mediated fever are very common in our day-to-day infection. Previously, we say that the biphasic fever is common with dengue or leptovirus. No, even this immune-mediated fever has now erupted as a cause of biphasic fever in a common condition like our typhoid fever. So these immune fevers are very, very common. Second, the other immune phenomena like classically our glomerulonephritis or rheumatic fever, it's a different ball game. But here this HLH is also there. We have a lot of cytokine storm in our COVID. So all these are immune phenomena where there is a cytokine dysregulation. And that's why the infection remains aside. Infection might have cleared from the body, but because of this immune mechanism, there is a lot of cytokine storm, there is a lot of lymphocyte dysregulation, and the child ends up in trouble.
So thank you, Abhay, for wonderful talk and very good interactions. We enjoy. Yes, Jagdish, you want to say something?
Thank you for that wonderful lecture, Abhayji. As usual, exhaustive, and also bringing out all the very important points. I think the basic problem with antibiotics in our country is lack of regulation. And I think we have to start looking at how to get the government to regulate the rampant use of antibiotics by every Tom, Dick, and Harry. If you look at most of even the MBBS and the non-MBBS so-called medical graduates, they use antibiotics more frequently than us, and for all trivial conditions, and use the most complex antibiotics. Dr. Jalil was mentioning about levofloxacin, but if you look at the commonest antibiotic used by, for a fever prolonged more than 3 days, it is one of the quinolones, or yes. Even I saw a prescription for the 4th generation cephalosporin by a person who is not even qualified to give an antibiotic. So I think these are all things that we need to probably take on an advocacy basis to try and see that the government regulates the use of antibiotics very strictly. Otherwise, we will be sitting on a time bomb. As you rightly mentioned, thinking through and using the right antibiotics is extremely good. Dr. Ritesh, I would suggest that you please put up your famous S2 so that everybody is very clear about what
Sure.
they are.
Exactly.
It's a very interesting thing, and I think it should be spread more.
Yeah.
Sure, sir. I'll definitely share. And with the extension of what you are saying, sir, I think ours is the country where it should start regulation from the manufacturing and approval side. You know that here we have even ceftriaxone and vancomycin as a combination. Can you imagine? Ceftriaxone and vancomycin as a combination, ceftriaxone and sulbactam, tazobactam, or whatever. So they offer to you whatever you like, sir. You know, and unfortunately, believe me, sir, I did one survey, and any irrational combination, this smart manufacturers, they go to surgeons first. They do not go to ID specialists. They do not go to physicians. They do not go to intensivists. They go to surgeons, and yes, there are lucrative combinations 1+1. So whenever we interact, by and large, it is very, very difficult to stop these combinations for using. Most of the surgeons, they start it, they realize immediately, maybe in a month or so, they go back to their previous regime. But by that time, the resistant weapon is shooted. Even few general practitioners, they also start. And as Abhay Bhai rightly said, I strongly feel it is underdose which kills the patient rather than anything else. Meropenem 500 milligram OD just to save the cost. Meropenem plus sulbactam, meropenem plus tazobactam, meropenem plus clavulanic acid. Can you imagine? I mean, there is no PKPD here. So regulation should start right from the manufacturer's side rather than anything else. There is no offense to surgeons. Please don't take me otherwise. Don't take me otherwise. But it is really necessary. We need to know our drug, what we are using. In our own hospital, ultimately resistant pattern starts.
And Satish Bhai,
Yes.
here Dr. Manoj Yadav has asked about autoinflammatory syndrome. I think this FAPA and Mediterranean fever, they are very, very, I would say very uncommon. But once in a while, we see it, but it's not seen with the routine infections.
Right. So thank you, Ritesh Bhai and Jagdish, for those suggestions. And I think it's time for us, for Saturday Club, also to organize a sort of panel discussion on these issues. And we'll invite some manufacturers also, Ritesh Bhai. So we'll make them answerable to why these combinations they are making. I think that
So believe me, when I took one lecture, branded versus generic drugs.
That's another
and
debate.
And not only doctors, the hall was full with 700 audience. And to my surprise, at the end of the lecture, I came to know that 20% of them were manufacturers. And it was difficult, tough time, but yes, we need to know that what we are using. That's my humble request.
Right. So thank you, Abhay Bhai, and thank you all for very active participation. So we meet next Saturday again for this meeting. Thank you all. We end the session here.
Thank you, everybody. Thank you for this opportunity. Satish Bhai, special thanks to you.